you all for today's session, Newer Cancer Treatment Updates 2025. And I would like to invite Dr. Sunil Kumar Gupta, sir. And he's a director and HOD, Department of Hematomedical Oncology, Venkateshwar Hospital, New Delhi, to give us a welcome introduction. So it's over to you, sir.
Thank you very much for such a kind introduction. Very good evening, dear friends. Ladies and gentlemen, at the outset, really thank the AstraZeneca who has given me this opportunity. There are so many new things coming in the treatment of lung cancer. And in last 1 decade, we have a next generation sequencing. And according to next generation sequencing, we are having a 9 targets to hit in adenocarcinoma. But the question is that so many things in clinical practice which is very important. A number of times these patients are treated as a case of COPD or as a case of tuberculosis for roughly 6 months to a year, and ultimately turn out to be a lung cancer. So first of all, our approach should be very clear that what is our approach in such patient. And first talk is basically based on this topic: what do physicians want to know about the lung cancer. And for that, I would like to call my colleague, Associate Director of Venkateshwar Cancer Hospital from Chest Department, Dr. Tarun Bhatnagar. He will tell us about that. What are the basic things required as a physician to diagnose the lung cancer? And once he will give his talk, we will discuss the other aspect. If there is any query from any audience side, Dr. Tarun will reply. I would like to call Dr. Tarun Bhatnagar to give his deliberations to all of us.
Thank you, sir. I would like to thank Dr. Sunil Gupta, sir, for inviting me for this talk. And as sir has rightly said, the cancers are evolving, and now they have become the number one diseases that is prevalent. Earlier it was there in the developed countries, but now they are more common in the developing countries like us in India. And my talk would be on the current lung management and what physicians need to know about it. So hello. I hope my screen is visible to all of you.
Yes, sir.
Okay.
So,
good evening, all. I am Dr. Tarun. I am an Associate Director at Venkateshwar Hospital, as Dr. Sunil sir rightly introduced me to. So, and my talk would be on current lung cancer management, what physicians need to know. Why it is important? Because I think the physicians are the first person to whom a patient visits. And they are basically a bridge or initial people who need to diagnose and figure out what are the symptoms of early lung cancers and refer us for the further treatment and management. Yeah. So this is the world data. So this is a Globocon world data. And as you can see, in the world, the lung cancer is the second most common cause of cancer after breast cancer. And it is just behind it. It is almost 11.4% as compared to the breast cancer of 11.7%. However, it is the largest cause of cancer death due to any cancer. So even though it is at number 2, the maximum number of fatalities are occurring due to lung cancer. The reason I would tell you in subsequent slides is basically it is diagnosed very late. In India too, the lung cancer is the fourth most common cause of cancer behind the breast and lip and oral cavity. Why lip and oral cavity? Because in India, a lot of people chew tobaccos, they chew gutkhas, and as a result, the lip and oral cavity cancers are most common. However, it's also a leading cause of cancer-related deaths. Again, the reason being it's very late to get diagnosed. As I've already told you in my earlier slides, and I've already communicated to you, that in India, only 14% of the lung cancers are diagnosed in an early stage. Most of them, the patients who have come to us are in the late stage, maybe in stage 3B or stage 4, or have, in simple words, we say that the lung cancer has spread to the whole of the body. So basically having distant metastasis. So if you see that the lung cancer in males who present to us, the distant metastasis is seen in almost 44% of the cases. And even in females, it is distant metastasis is seen in 47. So almost 50% of the males or females would have advanced lung cancers before they are diagnosed, as compared to a breast cancer, which is the most common cause of cancer. The local regional metastasis or rosal regional spread is seen in 57. So it is fairly early to pick up. So the earlier you pick up your cancers, the earlier you diagnose them, the treatment and the cure becomes easier and faster and long lasting. So as you see in this slide, the 5-year overall survival depends upon the stage in which you pick up. So in a stage of very early cancer, such as stage 1 or 1A1, the 5-year survival is to the tune of 92%, as compared to the advanced stage, which is stage 3B to stage 4. Again, the survival becomes less than 10%. So the whole idea of this interaction between a physician and the specialist is to diagnose and to look for early symptoms of cancer and to refer to us. What are the risk factors of lung cancer? The smoking is a leading cause of lung cancer. We all know about it. And 9 out of 10 cases of lung cancer in men and almost 8 of 10 cases of lung cancer in women is attributed to smoking. It is not only the active smokers who are affected, it is the passive smokers or the people who inhale the second-hand smoke are equally at risk. So it is not that the only people who are smoking, people who are not smoking, if you have a person in your house who is smoking, then also you are at an equal risk to getting a lung cancer. Family history has got a strong preponderance, and the people with first degree relatives, such as a parent, a child, or a sibling who has had a lung cancer, can have has a twice chance of getting a lung cancer. Other includes the exposure to certain industries, for example, uh, those who have worked in asbestos industries or where asbestos is there, or who are working in some nuclear thermal plants where radiation is high, or even in our hospital settings, the doctors or the paramedics who are working in X-rays and areas where there's radiation is high are also at risk of getting lung cancers. Now, what type of lung cancers? So basically, the lung cancers can be divided into two types: the non-small cell lung cancer and the small cell lung cancer. Then most of the lung cancer are the non-small cell varieties and are attributed to almost 85% of the total lung cancers. Among them, it could be a squamous or a non-squamous cell carcinoma, or even in the non-squamous cell carcinoma, the adenocarcinomas are the most common and account to 40% of the cancer of the lung cancers that is there. The next common is the squamous cell carcinoma, which is 25 to 30%. So totally, they almost attribute to 70% of the total lung cancers. The small cell carcinoma, which is also known as the oat cell cancers or the undifferentiated small cell carcinoma, account to approximately 10 to 15% of the total lung cancers that you see. The treatment is this why it is important, because the treatment is basically it's basically according to the tumor, which is whether it is a small cell or a non-small cell carcinomas. The treatment, I think, would be discussed much better by my subsequent speakers, and Dr. Sunil Gupta is a leading medical oncologist. We know about them. I'll just give a small gist about it. The small cell lung carcinoma accounts to approximately 12 to 14% of lung cancers, and the overall survival of the patients with small cell carcinoma is very low. It is less than 1 year, and maximum of the people live to a maximum of about between 7.2 to 11.4 months. Reason being late detection, and it is a very aggressive type of cancers. the advances in the treatment of small cell carcinoma, the small cell carcinoma treatment, the standard of care is often palliative with the combination regimens of either cisplatin or carboplatin with etoposide. So which was first started in 1985 where cisplatin and etoposide was introduced. And subsequently, we had another combinations which was carboplatin and etoposide, which was introduced in 99. Now, what we are using is an immunotherapy with a chemotherapy that needs to begin. So either we are using carboplatin, etoposide with acetylumabs or cisplatin, carboplatin with durvalumabs. So now the treatment is not only chemotherapy, but a combination of chemo and radiotherapy. The things who would be dealt in detail by the speakers who would be coming after me. The non-small cell carcinoma, as I've already told you, it accounts for approximately 85% of total lung cancers. And in non-small cell carcinoma, the adenocarcinoma is most common, followed by squamous, and others are relatively rare. In the cancer treatment, now we have a lot of target therapies that have come into it, and all them it is broken down to by the samples are broken down into the molecular genetics to look for any ALK, HER2, or any other mutations, because lot of targeted therapy is being offered to them, and it is improving the quality of the life, because when we are using targeted therapy, the probably the side effects are easy and the maintenance is better. Now, in the early stage and the late stage, the non-small cell carcinomas, the target therapy, I think, was first introduced in 2011 when crizotinib was approved for ALK positive non-small cell carcinomas. The lot of work has been done on it, and now in the last I would say 10 years, from first which was introduced in 2011 and now down to 2020, many target therapies have been introduced. The first one being crizotinib, followed by erlotinib, gefitinib, and now we are using brigatinibs and celebicidinibs for non-small cell carcinomas. Similarly, for advanced lung cancers, the chemotherapy was the initial treatment, but then came the immunotherapy, and now a chemotherapy and a combination of immunotherapy has become a standard of care for treatment of these cancers. In 2006, when the first immunotherapies was used, bevacizumab, to LAU-22, acetylumabs and ipilimumabs are being used with chemotherapies. So there has been a significant increase both for the approvals for both target as well as immunotherapies, and it has led to an increase in the overall survival status of the patients, even in the late stage of non-small cell carcinomas. Now, for any cancer, a multidisciplinary team is very important. We need to have the primary care physician who is a center. Then we also need to have a medical oncologist, a radiology to help interpret what are the scans, whether it is a contrast CT scans, non-contrast CT scans, or PET scans. A pulmonologist like me tries to give you tissues for the pathologist to work on the diagnosis. A pathologist not only gives us a diagnosis of small cell or a large cell carcinoma or a non-small cell carcinoma. In fact, now the pathologist's role has also increased to look for the mutations and the other microgenetics to help the oncologist. So it's basically a combination of it's basically a whole team approach for the treatment of carcinomas. And even in the later stage, a pulmonologist like me might help you in the palliative care if the to help relief of his breathing difficulties. Cardiothoracic surgeons are the most common stones of this management, because the cancers are curative if they are removed. So if you have an early stage cancers, surgeon would remove it. Oncologist will look, a pathologist would see the margins if they are positive for that. Oncologist would give him good chemotherapy and the patient would be disease free, and it has known to occur with lung cancers also. Now, management of early localized non-small cell carcinomas. Now, stage 1, 2, and 3. Now, stage 1 and 2 are the NSCLCs who are limited just to one lung and do not involve the mediastinum or any more distant site. That does not mean sometimes micronodal metastasis might be there. When in stage 3, the mediastinal lymph nodes are involved. The goal for early lung cancers is cure, which is a combination of surgery if it is surgically resectable, and also chemotherapy, which could be neoadjuvant or a later on chemotherapy. So, what is the standard of care or SOC? Number one is the diagnosis. So, we need to, any person who's coming with a lesion on an X-ray or CT needs a histopathological diagnosis to see whether it's a cancer or not. Also, we do a clinical staging as well as the distance staging to look for the metastasis. After that, there's a MDT, as I had already showed you 2 slides before, where we all sit together and form a comprehensive treatment plan for the patient to see whether the cancer is unresectable or resectable. If the cancer is resectable, then oncologists would decide whether a neoadjuvant chemotherapy to decrease the cancer load is required, or a radiotherapy is required, or the patient goes for surgery. During surgery, you have a pathological screening, and based on that, we decide whether an added adjuvant chemotherapy or a radiotherapy is required or not. So it's basically a whole treatment protocol. It's a whole treatment right from the diagnosis till the completion of treatment. The idea is to achieve a complete cure of the lung cancers. The surgical resections are the most common, and the most well known are the lobectomy. In lobectomy, we remove the whole lobe in which the cancer the pathology is there, the cancer nodule is there. This is important. This can only be done if it is in the center or towards the periphery. However, if the cancer or the lesion is near the larger airways or near the hilar, then in those cases, the pneumonectomy is better, where you remove the whole lung. Wedge resection and segmentectomy are basically reserved for very severe COPD patients on whom the lung reserves are poor. Maybe they are having bullous lung disease, where the complete removal of a lobe is difficult or sometimes impossible to achieve. What are the outcomes for early stage lung cancers? So again, surgery is the primary treatment for these cancers. Adjuvant cisplatin based chemotherapy has been recommended for both stage 2 and stage 3A, and in selected stage 1B patients. Large number of trials were done, and many of them found out that the addition of a platinum based chemotherapy actually does not overall improve the outcomes for lung cancers, especially in early stages. The overall survival benefit was not significant. So what next? Then came the drug osimertinib. Now, what did osimertinib did? They improved the disease-free survival. So if you compare both the slides, in which you see that on the graph on my left-hand side, you see in the overall population, in the patients having 1B, 2, or 3A disease, those who received this drug, the disease-free survival was excellent, to the tune of 90% in the first 24 months of their detections. And even after 5 years, the overall survival rate was very high, to the tune of 73%. It decreased the reduction of recurrence or the disease or death. Similarly, the primary endpoint, again in stage 2 and 3A disease, the survival at the 24 months was 90% as compared to 46%, and after 48 months it was 70% as compared to 29% in placebos. So this drug greatly improved the disease-free survivals and overall outcomes when used in non-small cell lung carcinomas. So adjuvant osimertinib provided a highly effective practice-changing treatment for patients with stage 1B, 2, 3A in EGFR mutations in non-small cell carcinoma, even after complete tumor resection. So they were adjuvant chemotherapies that were given. For unresectable locally advanced non-small cell carcinomas, again, when the mediastinal lymph node involvement is detected, patients are classified as having either stage 3B disease. In this, multidisciplinary treatment approach is important, where a pathologist, a radiation oncologist, medical oncologist, pulmonologist, and thoracic surgeons sit together. The treatment is chemoradiotherapy as a standard of care, and between the concurrent chemoradiation and sequential chemoradiation, concurrent chemoradiation or giving both the things together has found to improve the overall survival uh, in these advanced stage diseases. The survival rates, however, remain low, even in even with this in CRT unresectable stage 3 patients, when only what you said as chemotherapy was being given, until durvalumab were given, and improved the overall survival rates. What is the management of metastatic non-small cell carcinoma? So this is the area where these are the areas in which most of the people come to us. Majority of the lung patients actually come to us when or are diagnosed when they are in the stage 4. The treatment goals in this stage is basically extended survivals, in palliation, how to improve their quality of life and relieve the severe symptoms and limit the adverse side effects of the disease, as well as drugs if they are being given to the patients. The metastatic, now what we are doing, chemotherapy, target therapy, and patients who have got PD-L1 high, we can give the immunotherapies. So now basically the target therapy and immunotherapy, they are the main cornerstones and have become the mainstay of treatment for metastatic non-small cell carcinomas. So what is a target therapy? So target cancer therapy is basically when we identify a cancer target agent, maybe a gene, and we attack or inhibit the target cells, wherein we try to stop the growth of the cancer cells as a result, or may kill the cells also. How do we diagnose them, or how do we identify him? This is by molecular testings. It is on the same tissue sample. It is something like we do the drug sensitivity for bacterial cells to find out which drug is sensitive. It is something like that, in which we use the molecular testing of the cancer tissue to find out which mutations are there, and we try to use those specific drugs to kill those cells. Which are the targets identified? The 50% of the lung cancers, in 50% of the lung cancer, we have targetable mutations that can be seen. So now EGFRs are the most common targets that are seen. So the drugs that were used earlier was the geftinibs and erotinibs, and now we are using the latest or the newest generation, which is a osimertinib. What is the advantage of using these drugs? I am not a specialist, and I'm not I'm not the authority, but still, to give you an example, to introduce it, it is basically an EGFR sensitizing mutations, and the advantage of using this drug is that it is able to cross the blood-brain barrier. So even if you have, maybe you have cancer cells that have there in the brain, as in palliative intent, as to improve the patient's symptoms, you can use these drugs, and a single drug is helpful. You might not be using platinum-based chemotherapies. I don't know exactly. Dr. Gupta would be the person who would be sharing his views on it. Now, what is immunotherapy? Again, in immunotherapy, you have a tumor antigen, and you have a PD-1 receptor, or so you use a drug which is a PDL inhibitors, try to decrease the try to decrease those PD-1 inhibitions and CD80, and T cells are activated, and the tumor cells are gradually uh, killed by the own immune systems of the body. So it basically improves the immune system of the body to kill those cells. In advanced NSCLC, basically when are they used? When you don't find any mutations. Normally, it has seen the PD-1 mutations are seen in almost 50% of the cancer patients. In this, we use pembrolizumab with either platinum or based chemotherapies. And if we have a PDL1 which is lesser than 50%, then we use a platinum-based chemo therapy along with maybe a azacitidine or a bevacizumab. Now, just to summarize, I'm about my talk. The overall 5-year survival in non-small cell carcinoma patients is just 10 to 15% primarily, because majority of these patients come to us with either a advanced disease which is stage 3 or a metastatic disease which is a stage 4. So fewer patients are diagnosed in earlier stages. Also, as an high 30 to 60% of non-small cell patients undergo uh, undergo early surgeries, eventually develop metastatic disease. So there has to be a need to improve neoadjuvant or adjuvant chemotherapies even in the early stage to improve the outcomes. Adjuvant osimertinib will provide a higher effective practice-changing treatment for patients with stage 1B, 2, 3A, EGFR mutation non-small cell carcinoma even after tumor resections, as I have previously shown in my slides. So what is the largest unmet needs in lung cancers? So it is important that we improve the cancer lung literacy and awareness. That we know, sensitize the people what are the risk factors for the having the lung cancers, how we are able, what are the earliest symptoms of lung cancers, so that diagnosis and treatment is optimized. Increasing access to most innovative, lot of research has come up, a lot of target therapies are coming up. So again, we need to tell we need to upgrade our knowledge regarding it, evolve how we think about patient support, and reflect increasing survivorship in lung cancer. This is basically related to advanced lung cancer. We can have self-help groups. We have small WhatsApp group of people who have uh, improved on a certain drug. They can be helpful in telling those people. Very lately, Dr. Gupta has told us about the AIs. He's given a very good lecture on that. So how the AI may be used to help such people who have got lung cancers, and most importantly, early diagnosis of lung cancer uh, is the key, because majority of the cases are diagnosed later in stage when uh, the number of therapies and the outcomes of the therapies are very limited. So general physicians, they are the main partners in the management of lung cancers, because most lung cancers are costly and time consuming. And if the general practitioner or the first point physician is able to pick up initial symptoms and refer, we can get an early diagnosis, and that can be curative. So roles is they should have high index of suspicion of early and prompt diagnosis of the person is a smoker who's having a chronic cough. Instead of treating his cough, maybe a simple X-ray, look for subtle changes in X-ray, do a early CT scan to, or tell the patient to get a low dose CT scan, which is now a standard of care for early diagnosis of lung cancer. Then when you find out, you just refer to an oncologist or a pulmonologist for a histological diagnosis. Brief the patient about the importance of various tests. Sometimes we tell the patient that a biopsy needs to be done, and the patient does not come back to us because there's a common myth that if we take a biopsy, the cancer would spread. So talking to a person that these are all myths are important, taking care during complications, especially in advanced lung cancers, and follow up and treatment of recurrences. This is also one aspect that would be addressed at recurrences, what treatment, maybe second line of drugs that needs to be taken, also needs to be discussed. So thank you for your time, and thank you for your patient listening. If you have any questions, I would be happy to answer them. Thank you.
Thank you, Dr. Tarun, for such a nice, very clear concept regarding the what to know about the physician and how you will approach in patient those who are suspected case of a lung cancer. And you clearly and rightly said, if you provide the biopsy needs something. Once you are sending biopsy to the pathology department, number of time the doctors are unaware about what to do and how to proceed. And for that, I would like to call Dr. Bharat Dua. He's a senior consultant radiation oncologist at super specialty of Narayana Hospital. He will tell us about if he collect the biopsy from the chest physician, how he will approach in a biopsy, what are the principle of molecular diagnostic test and biomarkers. Dr. Bharat Dua will tell us regarding this. Now, Dr. Bharat Dua is basically a senior consultant and radiation oncologist at Narayana Super Specialty Hospital, Gurugram. Dr. Bharat Dua, please.
Yeah. Hi. Good evening, sir. Am I
Good
audible?
evening. Yes, Bharat, you are audible.
Yeah. Good evening, everyone. Good evening, Dr. Tarun, and thank you, sir, for the very nice introduction. And thank you for giving me the opportunity to speak here today. So I'll start with the first talk of mine. I'm taking this on behalf of Dr. Jyotika Jain. She's the head of the department at Radiation Oncology at Narayana. She couldn't be here today because of some urgent work. So I'll be taking this presentation in her stead. And as very nicely summarized by Dr. Tarun, biopsy plays a very important role in the diagnosis of lung cancer. And so once we have a biopsy, what do we do with it? And that's part of what I'm talking about. And the topic of my talk is molecular biomarker testing in lung cancer. So can I have the first slide, please? Yeah, so this is the content of my talk. We'll be addressing four things: lung cancer in India, biomarker testing, how it has evolved, and finally, we'll conclude with some key takeaways. Next slide, please. So the Globocan 220 data, Dr. Tarun has already presented this and sort of highlighted the importance of lung cancer and it being a growing concern amongst all the cancers in India. We'll just skip this slide because this has already been discussed. Next slide, please.
Sure.
Can I have the next slide, please? Yeah, so this is a very important slide, and this was briefly mentioned by Dr. Tarun during his talk that 50% of patients with advanced non-squamous lung cancer have driver mutations. Now, what does that mean? It means that the cancer cells have certain mutations which lead them to being targeted by certain medications, most of them which are given orally. As Sir mentioned in his brief introduction, there are 9 and as of now, possibly 12 mutations that can be targeted with oral agents. And as they are briefly mentioned in this slide, but I'll be discussing only a part of this. I'll be focusing on the EGFR mutation analysis today. And in the second part of my talk, in this talk, I'll be focusing on how do we test for these mutations. Suppose we have a biopsy sample as is mentioned in this slide, and as you can see, there are 12 different mutations that need to be tested for. How do we test them? What are the tests recommended? What is the standard of care? Will be the meat of my talk. Next slide, please. Yeah, so the importance of biomarker testing in lung cancer cannot be understated, as is seen in this very sort of short slide. There's been a definite benefit from all targeted therapies and overall survival. I won't extrapolate this to all targeted therapies, but this curve just sort of serves to highlight that if you have a targeted mutation versus a patient who doesn't have a targeted mutation, there's a definite benefit in overall survival if you're able to receive the requisite targeted therapy. So, can I have the next slide, please? Yes. So like most things in oncology, there are certain differences in how the guidelines sort of recommend testing, and three or four of the major ones are highlighted in this slide. There are certain differences between ASCO, NCCN, and ESMO, but we predominantly in our practice follow ASCO and NCCN. And as you can see, there are about 9 mutations that are uniformly recommended to be tested in any case of adenocarcinoma lung. And that's what sort of is highlighted in this slide. Can I have the next slide, please? Yeah, so this is a very important slide. So there are various ways of testing biopsy tissue for mutations, and the three major testing techniques are mentioned in this. The first tissue testing method is DNA sequencing, NGS, or PCR. Now, this particular technique is very good at detecting, as is mentioned in the slide, insertions, point mutations, and deletions. So what this technique detects is single nucleotide changes, and that's where NGS, PCR, DNA sequencing, and even Sanger sequencing comes in. The second method that is mentioned is RNA sequencing, and this is more important in detecting fusion abnormalities. Fusion abnormality is when one part of a chromosome undergoes a rearrangement and merges with another part of a different chromosome. And as is mentioned, the four molecular markers where this is seen are mentioned, and this is where RNA sequencing comes in. The third method that is mentioned is known as IHC of FISH. Now, IHC of FISH is predominantly a method to detect protein. Now, abnormal protein is often seen when there are fusions and also when there are point mutations, but IHC and FISH is predominantly recommended for ALK and ROS testing. And we'll come to this later on in the presentation. Next slide, please. Yeah, so let's just talk about the evolution of biomarker testing in lung cancer. Can I have the next slide, please? Yeah, so it's been a long journey. If you look at this slide, sort of shows the evolution of how testing has evolved. Initially, what we used to do, we had a biopsy specimen. We used to do a formalin fixed specimen. We had a formalin fixed specimen, and we used to do a basic morphology, histology, and cytology. And as Dr. Tarun also mentioned in his presentation, we used to classify the tumor as non-small cell or small cell. And then we used to further classify non-small cell CA lung as adeno or squamous or large cell. And that used to be it. That used to be the end of our evaluation, and our management algorithms were tailored accordingly. But as you can see in the extreme right part of the slide, this has changed. And the techniques that I've just mentioned are sort of reiterated in the right part of the slide. Our assessment methods have evolved. It's not simply enough to see the morphology and to know whether it is an adeno or a squamous sort of tumor. It's more important to know what is the mutational status of the tumor, and this determines management to a large part nowadays, not just in metastatic but also early and locally advanced lung cancer. Can I have the next slide, please? Yes. So the current recommendations, if you need to do a biomarker testing, both the primary tumor and the metastatic sites are equally suitable. Again, this is a slightly contentious point, and I'll be coming to a discussion on this in the later part of my slide. Bone biopsies are definitely suboptimal. Liquid biopsies are an option, but they have a large false negative value of about 30%, and that needs to be kept in mind. And as was mentioned previously and is mentioned again, the following mutations, that is EGFR, ALK, ROS, BRAF, NTRK, RET, MET, have to be tested in all non-squamous NSCLCs. And there are some other mutations that are being tested in more contemporary guidelines, but these are the important ones. And one very important point to note here is that there are two ways of testing. One is that you test sequentially. You test for a mutation. If that is negative, you test for another mutation, and so on and so forth. However, currently, what is recommended by most guidelines is broad-based testing. That is testing for all mutations simultaneously, which is known as broad NGS testing. And of course, testing for PD-L1 expression, which determines your responsiveness to immunotherapy, is also recommended, although this is not the bulk of my talk. And most guidelines, including ASCO, recommend that you should have the results of your mutation analysis within 10 to 14 working days. Can I have the next slide, please? Yes, so ctDNA testing or cfDNA testing, which forms the basis of liquid biopsies, and the full form of this is circulating tumor DNA, and it refers to cells that have sort of sloughed off the primary and are circulating in our bloodstream. They can also be used for testing mutations, but and they can be used at various steps. If at diagnosis, if it's difficult to get a biopsy, if you feel that the patient's medically unfit, or if there is a risk while doing the biopsy of a pneumothorax or some other complication. Also, you can use them to monitor therapy, and also at relapse if you feel the patient's condition is deteriorated, or if a biopsy sample is not available, or if perhaps you're not able to sort of get access to a good biopsy. You can use it to monitor response and to get a biopsy in the recurrent or the salvage setting as well. uh, it has certain advantages and disadvantages. The advantage is that since the cells have sloughed off from all parts of the tumor in the body, it takes into account tumor heterogeneity. One of the disadvantages, as I have previously mentioned also, is there's a false negative of 30%. And the current recommendation is you can use it, but it can never replace tissue biopsy entirely. If it's negative, then you should seriously consider doing a tissue biopsy. Can I have the next slide, please? Yeah, if you could just click through that. Yeah. Right. Thank you. Can I have the next slide, please? Yeah. So again, the concept of MRD. This is a very interesting concept. This is coming up. It's not validated in the guidelines, but this was a very interesting study. It was called TracerX, and what they did essentially was post-operatively they used ctDNA testing to determine if the patients have MRD, which means minimal residual disease. And they did find a significant correlation between patients who had evidence of MRD with ctDNA testing and recurrence. And the correlation was even before their disease could be picked up on follow-up by standard imaging. However, this is not currently recommended by any of the guidelines, and we are awaiting long-term follow-up. Can I have the next slide, please? Yeah, so we've already spoken about this, and this is a very nice summary of what I've just been talking about. And if you look at this slide, that's what it mentions. What I've been talking about, that the liquid biopsy is obviously a more simpler procedure. It's minimally invasive, and while it can tell you the mutational status, one very important point to note is that the liquid biopsy cannot tell you regarding the tumor type. It cannot tell you whether it's an adeno or a squamous or a large cell or even a small cell. Although the mutational analysis that it does sort of corroborates with histology, but it cannot directly tell you the type of the tumor. And this is a very important point to note. And obviously, standards have not been defined, and the evidence is slightly less than what you have for the contemporary tumor tissue biopsy. But yeah, it's coming up in a big way, and the NCCN strongly advocates considering it at all parts of the patient treatment paradigm. Can I have the next slide, please? Yeah, this is sort of been highlighted. So yeah, again, so single gene testing or multiple gene testing, we've already discussed this. So one pathway to doing mutational analysis, that you test for each gene sequentially, or you can test them sort of together. And what is recommended by most guidelines, and particularly the American ones, is that you test for them together via broad-based testing, something like an NGS. Can I have the next slide, please? Yeah. So that's what we're talking about. And let's get down to the meat of the presentation. What are the advantages of NGS? Can I have the next slide, please? Yeah. So obviously NGS has pros as well as cons. Now, the advantage obviously is because it's a broad-based test, it can detect a number of alterations simultaneously, and also potentially some new ones, which could facilitate correlation with prognosis and further studies. The problem is that obviously it's a very complex test. It takes a little longer than if you were doing single gene or reflex testing or sequential testing. And of course, it has also led to the detection of something called variants of uncertain significance, or VUS, and we really don't know what to do with that as of now. The recommendations are very gray regarding that. Can I have the next slide, please? Yeah, so again, there's a very large array of tests that we have, and if you just look at this slide, this is a very interesting slide actually. So what this shows is on the right you have types of variation. So SNVs and CNVs. SNVs refer to single nucleotide variants, and CNV refers to copy number variants. In a nutshell, what SNV means is point mutations, insertions, deletions, and CNV refers to amplifications and deletions, large scale translocations, or inversions. And as you can see, if you look at NGS, which is highlighted in yellow, it is equally good at detecting both SNVs and CNVs. And this does not apply to a lot of tests, as you can see it in this slide. Can I have the next slide, please? Yeah, and so a very complex molecular landscape, and I think we'll move on to a more pertinent slide in the later part of the presentation. This is a very sort of jammed up slide. It tells you about the possible mutational alterations and their drugs, but this is coming up in a future slide. So can I have the next slide, please? Yes. So let's get to the bulk of my presentation. Let's talk about EGFR mutations and how do you test for them. Can I have the next slide, please? Yeah, so it's a very important slide. You can use formalin fixed sections, you can use alcohol fixed sections, you can use cytology samples as well. And one very important point is that you can use either the primary or the metastatic site for testing for EGFR mutation status in a patient. Discordances are rare, they are to the tune of about 5%. Can I have the next slide, please? Yeah, so there's a definite role of EGFR testing in early lung cancer as well, and I mentioned this that mutational analysis in this present day and age is not just restricted to metastatic lung cancer, but also early and locally advanced lung cancer as well. Can I have the next slide, please? Yeah, and the NCCN also recommends testing for EGFR, and this is recommended in stage 1B to 3A as of now. And this was briefly alluded to by Dr. Tarun as well, that EGFR testing has relevance in early stage lung cancer because of a drug called osimertinib, which has come in big way and is recommended in adjuvant therapy of early and locally advanced lung cancer. Can I have the next slide, please? Yeah, that's what is mentioned. So yeah, okay. So NGS over PCR is, as I mentioned, PCR is a targeted way of testing. So PCR refers to a polymerase chain reaction, and NGS refers to next generation sequencing. NGS is better at detecting rarer mutations than PCR, and that is what is highlighted in this point. So can I have the next slide, please? Yeah, coming to the further mutations that are seen, let's talk about ALK rearrangements in lung cancer. Can I have the next slide, please? Yeah, so as I mentioned briefly before, IHC testing is recommended in two mutations right now. One is ALK and the other is ROS. Perhaps the only two mutations where IHC has a role, although the role is predominantly in screening. For ALK, if the IHC is FDA approved, you can use it to start therapy. And this is mentioned in the NCCN and ASCO both. And obviously, the advantages is that IHC is less expensive. So, wanted to highlight this point here. Can I have the next slide, please? Yeah, coming to ROS rearrangement. Can I have the next slide, please? Yeah, so it's very interesting, and there's a bit of discongruence in the guidelines. If you look at ALK, IHC, and FISH testing is recommended. For EGFR, it's PCR and NGS. For ROS, both the algorithms are possible. You can screen with an IHC, or you can screen with more advanced techniques like FISH or NGS. And even if you get a positive report or a fish, it's still recommended that you do a double confirmation with an IHC. And the same goes for an IHC. If you get a ROS positive or an IHC, you still need to confirm with a fish or another molecular assay. And this particular algorithm is unique to ROS mutational testing. Can I have the next slide, please? Yes. So coming to a very important concept in lung cancer, that is KRAS mutations. If you look at the top left of the figure, KRAS is and it's a protein that plays a part in the EGFR pathway and is essentially a GTPase. So what it does is it signals a number of pathways, and if it's mutated, leads to constitutive EGFR cycle signaling. And again, it's a very difficult protein to block, although we've managed to do that. But it's notoriously difficult to block. And the most common mutation that are seen in KRAS are seen in codon 12 and 13. Initially, it was thought that KRAS mutations are mutually exclusive, but now that's not found to be the case. And which is the reason why broad based testing is recommended for all genes, including KRAS. Can I have the next slide, please? Yes, another protein downstream of KRAS is RAF. Again, it plays a role in the EGFR pathway, as you can see at the top left. Again, RAF can also be blocked by what we call BRAF inhibitors. And an example of these are dabrafenib and trametinib. Again, the detection method for BRAF mutation is generally NGS. And if you read the latest version of the NCCN guidelines, IHC and FISH play a lesser role. The recommendation is to get an NGS done for BRAF mutation testing. Can I have the next slide, please? Yeah, MET. So MET is another receptor tyrosine kinase, and again plays constitutive MET signaling. Again, is one of the possible pathways for carcinogenesis. Now, MET undergoes what we call in-frame deletions and normal and abnormal splicing. So what is happening is it's undergoing rearrangements. And if you remember the beginning part of my talk, I mentioned that when it comes to rearrangements, RNA NGS is slightly better than DNA NGS at detecting fusion and rearrangements. And the same is mentioned in most MET testing algorithms. If you look at NCCN and ASCO, they do mention DNA NGS as an option, but they state that RNA NGS might be slightly better. So can I have the next slide, please? Yeah, so again, a bottom part of that slide highlights what I was trying to say. DNA detects many mutations, DNA-based NGS, but RNA-based NGS at present is the most sensitive. So we should remember wherever there's a gene mutation that is predominantly of a fusion type or a rearrangement, RNA NGS is better than DNA NGS. Can I have the next slide, please? Yes, another gene that undergoes rearrangement is RET. Again, it's another receptor tyrosine kinase, and while the it's a very rare mutation seen in only 1 to 2%, but yes, it's a targetable gene, and we have 3 drugs at present that can target RET. And again, if you look at the bottom left part of the slide, the same thing is mentioned. If it's a fusion, DNA NGS is good, but there is increased sensitivity with RNA NGS, and that is the method that is recommended for RET testing. So can I have the next slide, please? Yes. So again, if you see the slide, it's just highlighting the same thing as it was in MET. So DNA and RNA NGS are the predominant options or the ways for RET testing, and RNA NGS is slightly more sensitive and should be preferred. Can I have the next slide, please? Yes, again, so NTRK again is a protein, it's a receptor tyrosine kinase. And again, as you can see at the top of the slide, it undergoes fusions. So again, it lends to common sense that NGS would be the method of choice, and RNA NGS would be more sensitive than DNA NGS. But most guidelines mention that for NTRK, DNA NGS is nearly equal to RNA NGS. This is different as compared to MET or RET. Can I have the next slide, please? Yes, again, again, now this slide is just highlighting advantages and disadvantages of the 3 methods. While it doesn't specifically pertain to NTRK, it's useful to go through it. If you look at IHC, we know it's a simpler method. It will give you rapid results. It's low cost. It's widely available. And the same goes for FISH. And if you look at NGS versus IHC, it's a little more complex. There are longer waiting times, there's cost, but again, it can test multiple genes simultaneously. And because it's testing for multiple genes simultaneously, it's particularly beneficial where there is a paucity of tissue. If your biopsy sample is not very adequate, you should prefer an NGS or a broad-based NGS for your mutational testing. Can I have the next slide, please? Yeah, so HER2 mutations, this is something new and it has come up. If you see the NCCN guidelines post 2022, HER2 mutations, as compared to breast cancer, it's a slightly different paradigm in lung cancer as compared to breast cancer, where you see mostly amplification in breast cancer. Here you see mutations. And hence, there is a role of IHC in HER2 testing in lung cancer. Can I have the next slide, please? And if you were to just summarize what we've discussed, so this is the slide I was pertaining to. This mentions most of the targeted agents that we have, and I just like to go through this one by one. So if you look at EGFR, the drugs that we have depend on the type of mutation. If it's a classical mutation, that is exon 19 deletion or L858R. Osimertinib is the drug of choice. If you look at the uncommon mutations, exon 20, we have amivantamab or mobocertinib, which is not now FDA approved and has been removed from some of the guidelines. And if you look at the uncommon mutations, the 768, 861, and 719, then you have either osimertinib or afatinib, which is a second generation EGFR TKI. If you look at ALK, then the drugs that are mentioned are alectinib, brigatinib, or lorlatinib. Ceritinib and crizotinib are, of course, the first-line drugs. And if you look at ROS, then the drugs are crizotinib or entrectinib. If you look at BRAF, then it's dabrafenib and trametinib. If you look at NTRK, which we just talked about, it's entrectinib or larotrectinib. If you look at RET, it's selpercatinib or pralsetinib. If you look at MET, then it's capmatinib or tepotinib. And another drug that's not mentioned here but is advocated in the NCCN guideline is crizotinib. And lastly, coming to KRAS G12C, the drugs that are mentioned here are sotorasib, but of course, adagrasib is also now advised in the NCCN guidelines. Can I have the next slide, please? Yeah, coming to the last part of my talk, PD-L1 overexpression in NSCLC. This is important for selecting patients for immunotherapy. And what's very important to note is that each of the drug has a separate antibody clone, an IHC platform, and a scoring system. And when you're testing, you must take this into account. If you're planning to give a patient pembrolizumab, you must ensure that the correct antibody clone and the IHC platform has been done. So can I have the next slide, please? Yeah, so this has already been discussed. Can I have the next slide, please? Yeah, so again, this is controversial, but I believe we are nearing a solution. If you look at the latest guidelines, in between, there was a slight discordance between PD-L1 testing and the responses in patients. Tumor mutational burden has largely been removed from lung cancer guidelines, and MSI is obviously not relevant. PD-L1 testing is relevant and does predict responses. So I believe we are coming to a solution. And LAG3, again, is a marker that is being studied because it is often seen in patients who are resistant to immunotherapy, but we don't have a licensed FDA-approved targetable agent, at least in lung cancer, for it yet. Can I have the next slide, please? Yeah, so I'd just like to conclude my talk. So biomarker testing has evolved from single to multiplex testing. You have to test for multiple genes simultaneously. You need adequate tumor content. Obviously, if you're testing for multiple genes via NGS, the turnaround time or TAT, as we use it in common parlance, is 2 weeks, ideally 10 days. And wherever possible, use a high throughput platform like NGS. Thank you.
Thank you, Dr. Bharat, for such an excellent talk regarding and crystal clear concept regarding the biomarkers role. I personally feel that this is the future of cancer treatment. And even today, we are going for all the targets to hit The drug available in India, we are practically using from bench to bedside. And I would like to call again for your another deliberation on advanced EGFR mutation or non-small cell lung cancer, evidence-based review of targeted therapy. Dr. Bharat Dua again, please.
Right. Thank you, sir. Thank you. So I'll begin the second talk as soon as the slides are, yeah, so the slides are up. So good evening, everyone. I'll begin the second part of my talk. Now, what I'll be talking about here is how do we manage EGFR mutated lung cancer in the contemporary age. I'll be looking at some evidence and discussing some guidelines, and finally concluding with the best possible paradigm. So can I have the next slide, please? We've already discussed the epidemiology. Can we move ahead? Yes. So, yeah. So, of course, the survival, as the stage advances, the survival decreases. And what is mentioned is that if you look at the bottom right part of the slide, that the survival in stage 4 at 5 years is about 0 to 10%. Well, I slightly disagree with that. It's become slightly better nowadays with targeted therapies and immunotherapies, and it's for 4B it's closer to about 7%, and for about 4A it's closer to about 15%. And can I have the next slide, please? Yes. So again, I cannot stress the importance of this slide. This has been previously discussed, but we'll keep coming back to it again and again. Almost 50% of stage 4 lung cancer patients have biomarkers. They are targetable, and the importance of NGS cannot be overstated. So can I have the next slide, please? Yeah, so we've already discussed this. We've discussed the paradigms for mutational testing for EGFR, ALK, ROS, and PTL1 in my previous slides. So we'll move on from this. Can I have the next slide, please? Yeah, so coming to EGFR, which is the meat of this talk, the most frequent mutations that occur in EGFR are in exons 19 and 21. However, we should at present test for exons 18 to 21, which is recommended by most guidelines. As you can see in this, although exon 19 and 21 are the most common mutations, there are some rarer mutations that are seen on exon 18 as well, as you can see in the middle left part of the slide. So can I have the next slide, please? Yeah, this is important. While the prevalence of EGFR mutations in Caucasians is about 20% or 25% as per the latest data, in Asians it's about upwards of 40 to 45%, and which just sort of serves to illustrate that it's so important to test our Indian patients for EGFR mutations upfront with an NGS-based platform. And what's interesting is that the stage-wise distribution is more or less consistent. So can I have the next slide, please? Yes, this has been discussed before, but this is not the bulk of my talk. But yes, now there's a drug that was discussed before, osimertinib, that has come up in a big way in the adjuvant setting in early and locally advanced lung cancer. And so EGFR testing is not something that is restricted to metastatic lung cancer, but any lung cancer beyond stage 1B needs to be tested for EGFR. So can I have the next slide, please? Yeah, so this slide serves to highlight how EGFR works, and what this is trying to show is whatever happens, whichever mutation happens, the basic endpoint is constitutive signaling of EGFR. This leads to oncogenesis via various processes. It leads to aberrant protein synthesis. It leads to cell proliferation. It leads to enhanced cell survival. And this is as contrast to wild type EGFR, which only functions when the appropriate ligand binds it, as compared to mutated EGFR, which does not need a ligand to bind it. It's constitutively active. And this is what this slide serves to highlight. Can I have the next slide, please? Yeah, so this has been discussed somewhat previously, and I've already mentioned most of the targeted agents that are used. And this slide is the treatment paradigm for metastatic lung cancer. It highlights some guidelines, but of course, there is a discordance. So what it mentions is the treatment paradigm for both adeno and squamous. And because squamous cell carcinoma does not have a lot of mutations, the incidence of mutations is less than 10%. It's important to test for PDL1 upfront and manage it accordingly. So can I have the next slide, please? Yeah, so again, we'll be coming to this. Let's talk about the drug first. Yes, so osimertinib is a third generation tyrosine kinase inhibitor. So I'll just highlight each of the words that are written on the slide. It's third generation. It's an irreversible tyrosine kinase inhibitor, which is different as compared to the first generation drugs. It's CNS active, and what that means, it has good CNS penetration, and this has been demonstrated by trials as well. It's selective for both mutated EGFR and also for something called EGFR T790M, which is a very common mechanism of resistance to first and even sometimes second generation TKIs. Can I have the next slide, please? Yes, and coming to a very important study. Uh, so one of the caveats of managing EGFR mutated lung cancer was that how do you sequence therapy? Should you start with a first line agent and wait for resistance to happen and then put the patient on a second or a third line drug like osimertinib? Or should you start with the best drug upfront? Or should you start with a third generation TKI upfront? And this is what this trial sort of served to study. It attempted to address the benefit of a third generation versus a first generation TKI, and also to shed light on what should be the appropriate treatment sequencing in EGFR mutated lung cancer. So let's discuss this trial. Next slide, please. Yeah, so let's look at the trial diagram. So again, locally advanced or metastatic NSCLC, the inclusion criteria were age above 18, performance status 0 to 1. And so this trial took the common EGFR mutations, exon 19 and L858R, and stable CNS metastasis were allowed. And what that means is that the patient either had to be neurologically stable or the patient had to have treated CNS metastasis as per the trial protocol. There was a pre-stratification according to the mutation because we know L858R is associated with a poorer prognosis. And there was also a stratification according to race. And the patient were randomized to two arms. One was osimertinib, which is the third generation TKI that we've been talking about. The dosing was 80 mg once daily. Versus standard of care, both gefitinib 250 mg once daily or erlotinib 150 mg OD were allowed. And response assessment was with RECIST 1.1. One very important point is that crossover was allowed, which means that a lot of patients that received first generation TKIs were allowed to receive osimertinib or the third generation TKI at progression. And this has overall survival assessment implications, which we'll be discussing. Can I have the next slide, please? Yeah, so as you would expect from a randomized trial, most baseline characteristics which determine or could determine prognosis were well balanced. Some of the important ones were CNS metastasis, stage 4 versus stage 3, histology, and also the type of mutation. So these were well balanced between the two arms, which means the results had good external validity. Can I have the next slide, please? Yes, so let's come to the efficacy assessment. The primary endpoint of most tyrosine kinase inhibitor trials has been PFS. And the good thing was that while there was investigator assessment, there was always also a BICR in this trial, which sort of lends most strength to the results. This is a curve which showed the efficacy of PFS assessment at 60% data maturity. And as you can see, there is a very good separation of the curves. And while the PFS in the standard of care was about 10 to 12 months, as we usually see with a first generation drug, in the osimertinib arm, the median PFS was almost 19 months. That's almost a 1.5 times improvement. And if you look at the hazard ratio, there was almost a 54% relative reduction in the risk of progression. Can I have the next slide, please? Yeah, so this was so there's pre and so there's a ad hoc and a post hoc analysis. And if you look at the forest plot, there were certain characters that were stratified at baseline, and there are certain characters that were characteristics that were addressed retrospectively. There was no subgroup where there was a lack of benefit to osimertinib, and this is a very important point that needs to be noted, and was one of the highlights of this trial. Can I have the next slide, please? Yeah, so if you look at the left, the response rates were not very different. If you look at the first generation comparator arm of 76% response rate versus 80% in the osimertinib arm. But what was really different was the duration of response, or the DOR, which was a very unique and new endpoint that was assessed in this trial. So the DOR was almost doubled with osimertinib as compared to the standard EGFR TKIs. And again, one of the highlighting points of this trial. Can I have the next slide, please? Again, so yeah, so this is again a very interesting point. Most of the EGFR TKI trials that have been done previously had given a PFS benefit, but not a lot of them had shown an OS benefit. And this is one of the few trials that has. And if you look at the curves, they start separating very quickly. And there was a very good OS benefit, and this really cemented osimertinib as the first line therapy in EGFR mutated lung cancer. And if you look at all the guidelines of 2024 and 25, most of them say that osimertinib is now the preferred agent of choice for first line therapy in EGFR mutated lung cancer. Can I have the next slide, please? As expected, there was a very detailed adverse event analysis done because there is no point in having a OS or a PFS benefit if the adverse event profile is deleterious. And fortunately, there were no new adverse event signals, and the toxicity was very manageable and largely comparable to the first generation TKIs. Can I have the next slide, please? Yeah, so this is the safety analysis data set. If you look at it, there are no sort of new safety signals that come up. The toxicities were more or less balanced. In fact, if you look at the grade 3 toxicities, they were slightly less in the osimertinib arm as compared to the standard of care arm. Largely, if you look at casual versus non-casual, the relationship still holds. Possibly casual related. Again, if you look at grade 3, they were less in the osimertinib arm as compared to the standard of care arm, and this is a very important point to note. Can I have the next slide, please? Yeah, so if we were to summarize the study, so obviously the most significant benefit was in PFS, where the hazard ratio is 0.46. There was improvement in CNS progression-free survival as well, and this is coming up in the subsequent slides, where the hazard ratio was similar to the PFS benefit and led to fewer CNS progression and fewer new CNS lesions. The final OS analysis was very interesting. The hazard ratio was 0.799 with an upper limit of 0.88, and the p-values are also significant, which means that there was a PFS benefit translating into OS benefit. And this is very important because if you just see the previous slide, crossover was allowed in this study, which means there were a lot of patients that were getting osimertinib when they progressed on the first generation TKI. And what that means is that the giving osimertinib later on cannot make up for giving it earlier on. And this is a very important point that came through from this trial and played a large sort of role in determining the sequencing of our current therapies. So can I have the next slide, please? Yeah, so although I've already mentioned this in brief, but we'll be discussing the CNS efficacy for osimertinib in detail. So can I have the next slide, please? Yeah, so this is a pooling of various phase 2 and phase 3 studies, and most clinicians know this, that CNS metastases occur at a higher rates in those patients who harbor EGFR mutation as compared to wild type EGFR, and the incidence is almost 10% higher. So can I have the next slide, please? And so assessment of CNS response was obviously a very important endpoint of the study. And again, this is from the FLORA trial. If you look at the curve on the left, they are the curves for the patients with CNS metastasis. And if you look on the right, they are the curves for patients without CNS metastasis. If you look at the hazard ratios, they are more or less similar. And if you look at the divergence of the curves, the pattern is very similar. The curves start to diverge early and the divergence is maintained, which means that the PFS benefit is maintained with time. And this is very relevant in patients with brain metastasis who otherwise have a very poor prognosis. Can I have the next slide, please? Yeah, so again, looking at the full analysis data set, whether the patients had a CNS metastasis or not. Again, if you look at CNS PFS, the curves are still diverging, the divergence is maintained. The hazard ratio is similar to the hazard ratio for the subgroups at 0.48. And this is again one of the highlights of the study. The CNS efficacy of osimertinib was something that really needed to be studied, and this will be relevant as we come to the future slides. Can I have the next slide, please? Yeah. So again, so up until now, we have compared osimertinib to first generation TKIs, that is gefitinib, erlotinib. Now we will start to compare osimertinib to second generation TKIs, and the first one that we are comparing it to is dacomitinib. Can I have the next slide, please? Again, you shouldn't do cross trial comparisons, but again, so because they've not been compared head to head, we look at cross trial comparisons. So Archer 1050 was a trial that compared second generation TKI to first generation TKI. It compared dacomitinib to gefitinib. And again, while I can't stress this enough that you should not do cross trial comparisons, but if you just look at the survival curves on the left, so if you look at first versus second generation TKI, the benefit in PFS does not start to appear till about 6 to 9 months. But this is not the case when you look at the right. This is the data from the Flora trial again. The curves, when you compare a first to a third generation TKI, the curves start to separate immediately. And the separation increases with time, the separation is maintained with time. So can I have the next slide, please? So again, as I mentioned, although most trials have shown a PFS benefit, not a lot of trials have shown OS benefit. And this was one of the problems with the Archer trial. Although it did show a PFS benefit for dacomitinib, it did not show an OS benefit, which is why if you see the guidelines, the first line recommended therapy for EGFR positive patients also includes dacomitinib and gefitinib. Can I have the next slide, please? Yeah, so we've already highlighted this. Can I have the next slide, please? Yes. Yeah, so another problem with the Archer trial was it used a hierarchical design. So hierarchical design is where you analyze endpoints sequentially. If you get a significance for one endpoint, only then do you assess the analysis or the significance analysis for the second endpoint. Now, because it had a hierarchical and hierarchical stratified design, and it did not meet a benefit in one of its primary endpoint, that was ORR, it could not do a significant analysis for the OS. That is, it could not determine a p-value. And this is one of the problems with hierarchical designs. If you don't get a benefit in the first endpoint, you are sometimes unable to properly assess the benefit of the second endpoint. Can I have the next slide, please? Yeah, so coming to the comparison of osimertinib, a third generation tyrosine kinase inhibitor, with another second generation tyrosine kinase inhibitor, which is afatinib. Can I have the next slide, please? Yeah, again, we'll be doing cross trial comparisons, but yes, just let's just look at this trial. So this is Lux Lung 7. This is a very famous trial. This is what really brought afatinib to the 4-4. Again, it showed a PFS benefit, and in most subgroups, there was a lack of benefit, or there was evidence of a lack of benefit in some patients who are perhaps light smokers. But again, this has not been seen in real world data. And again, insufficient ends to determine OS. And if you just look at the PFS in this trial, it's 11 months. And again, as we've discussed previously, osimertinib has a median PFS about 19 months. But I'll stress again, you should not do cross-trial comparisons. Can I have the next slide, please? Yeah, so again, see, if you see the curves, they're showing a intersecting pattern. So there was evidence of a separation, but then they intersect. And biologically, although this is very important, but again, if you look at from a trial point of view, it did not meet its p value. And what they state was that there was no long term evidence of an OS benefit. And again, as I mentioned before, this is the reason. If you look at the NCCN guidelines and you see the treatment options, osimertinib is preferred, but then first and second generation TKIs are more or less equal in terms of their efficacy. And this is why. Can I have the next slide, please? Yeah, so again, this is just a further analysis of the Lux Lung 7. They tried to assess if there was some difference in exon 19 or L85 or 8R, but again, they did not find any. Can I have the next slide, please? And again, this has been stressed again and again. One of the main advantages of osimertinib versus the second generation TKIs is that if you read up all the trials, you'll find that the second generation TKIs are the most toxic. They are even more toxic than the first generation TKIs, and this is where osimertinib really brings its weight. Osimertinib is slightly, or I would say slightly or less toxic than first generation, but it is markedly less toxic than the second generation. And this is one of the main advantages of using osimertinib. Can I have the next slide, please? And yes, a very important point that I wanted to highlight in my presentation. Flora was not just a trial of first versus third generation TKI upfront, it was also a trial of sequencing. As I mentioned, the standard of care or the first generation TKI arm patients were allowed to have third generation TKI at progression, and a significant patient number received this. First line osimertinib still maintained its better results even in OS, despite there being a significant crossover. So this resolved the dilemma. This has resolved a significant dilemma that we've been having as clinicians. Do we give first line TKIs and then wait for progression and then give the third line TKI, or should we give the third line TKI upfront or the third generation TKI upfront? And this dilemma has been resolved by the Flora study, and as of now, that is why osimertinib is the preferred first line therapy for EGFR mutated lung cancer. Can I have the next slide, please? Yeah, so lending further support to that theory was that perhaps if you give first generation TKIs and then you have something called a T790M mutation, which is a very common mechanism of resistance, giving osimertinib at that point would give the patients who have this mutation an opportunity for treatment or a second line therapy. However, what has been seen in trials is that almost one third patients, or rather to the tune of 35%, almost 35% of patients are unable to get any second line therapy at all, regardless of which first line TKI they get, whether it is osimertinib or gefitinib. And this has sort of diluted the possible benefit that osimertinib could have had in the second line. So can I have the next slide, please? Yes, and so again, as I mentioned in the second slide or the previous slide, it is not possible to predict who's going to get this mutation. A lot of patients, despite this mutation, are not able to receive second line therapy. So, on the basis of this and on the basis of that trial, most guidelines have concluded that you should start with the drug with the maximum efficacy upfront. Can I have the next slide, please? Yeah, and again, the fact that patients did not receive second line therapy in the trial is consistent with real world data. And this was perhaps one of the worries that was highlighted in the trial. Is it possible that patients that are not receiving second line therapy in the trial are different from the real world population? No. So even in real world data, almost one third patients are unable to receive second line therapy. And those that do, a significant proportion of these do receive osimertinib almost to the tune of 50%, because T790M is such a common mechanism of resistance if you put the patient on first line therapy. And this just serves to highlight the fact that the benefit of osimertinib will persist even if you start a patient on a first generation TKI and subsequently give them osimertinib versus giving the patient osimertinib upfront. The patient who's gotten osimertinib upfront will still do better. And this is what I wanted to highlight with my data. So can I have the next slide, please? Yeah, so this is just a corroboration that even in the real world, if you look at the real world data, less than 2/3 are able to receive second line therapy. Can I have the next slide, please? Yeah, and there it is. So this is what we were mentioning, and this is the NCCN version 1 2024. But even if you look at version 1 2025, it's still the same. It's osimertinib as a preferred recommendation in EGFR positive lung cancer. However, if you look at the other recommended therapies, if you look at the first and second generation TKIs, you'll notice that most of them have a category 1 recommendation. And this is simply because most of the trials, although they've shown a PFS benefit, they've not shown a consistent OS benefit. So it's not possible to choose amongst them at present. Can I have the next slide, please? So I'll conclude my talk. Again, the first point being the most important, that osimertinib is one of the few TKIs that has translated a PFS benefit to an OS benefit. The PFS right now stands at 18.9 months. The OS stands at close to about 3 years. And it has shown significant efficacy in CNS metastasis. And for patients, for clinicians who treat such patients, they note that a significant proportion present with brain metastasis up front. And so this particular efficacy is very important. The safety profile of osimertinib is very manageable. And hence, if you just sort of go through the NCCN ASCO guidelines, osimertinib is the new standard of care for first-line therapy for EGFR mutant advanced lung cancer. Thank you.
Thank you, Dr. Bharat, for such an excellent, clear-cut idea regarding the third generation TKI role as a upfront and even the CNS mets. And you basically did wonderful job for me, because you can given my job very easy, because you mentioned about the CNS mets.
Right.
So I would like to talk on a brain mets, and everybody knows about that. Once there is a brain mets in lung cancer patient, our radiation oncologists play important role. And Dr. Bharat Dua, I always call Dr. Bharat Dua like radiation oncologist for a palliative radiotherapy, SBRT, if there is a single mets or a maximum 3 to 5 mets. But how the third generation TKI play important role even in brain mets, I would like to discuss with that issue with you. Please show my slides. Please, hello. Hello. Please share my slides.
Yes, sir. Wait for a second.
So my talk is basically on a reimaging CNS mutation in EGFR advanced lung cancer, how treatment compare. And Dr. Bharat Dua clearly mentioned about that very clearly, first generation, second generation, and third generation TKI. And even we are having a more new drugs, fourth generation TKI in future to treat the adenocarcinoma lung cancer patient, those who are having a EGFR mutation. Next slide, please. Next slide, please. So, as Dr. Tarun and as Dr. Bharat mentioned very clearly, that 85% patients are non-small cell lung cancer and 15 to 20% patients are small cell lung cancer. Next slide, please. And you can see the data, means very clearly they mention about that. But the important thing which I want to highlight, as Dr. Bharat Dua mentioned about that, the magnitude of EGFR mutation, if you see, average is 17%. But this is not the real world picture. I am discussing a real world picture to you. Next slide, please. Next slide, please. Just see the global picture of EGFR. And this is swinging from 15% from Europe to 62% in Asian country. So what is the global picture of EGFR mutation I'm highlighting, and how the response is changes with the mutations number as per the geographical picture. If you see the North America, this is in the tune of 22 to 27% average. While in Latin America, this is again similar in data. But just see the Europe, which shows a very less number, roughly 50% as compared to the United States, or you can say the Latin American persons, 12% versus 16%. And just see the Middle East. I'm showing the Middle East data, which is much less. 8 to 12% only, while the Asian patients are having 36 to 40%, or the Africans again have a similar 22%. Even the Australians are having 24%. Next slide, please. So, patient with lung cancer has a higher rate of identified brain mets, as Dr. Bharat Dua clearly mentioned about that. Those who are having EGFR mutation, they are roughly 10% more prone for brain mets. Such incidences are more pronounced in EGFR mutation. And I would like to say, wild type seen only mutations, 22% brain mets. If there is a EGFR mutation, this increases almost double in the tune of 44%. Leptomeningitis is one of the poorest clinical presentation of brain mets, and you can say survival is roughly 4 to 6 weeks. And leptomeningeal meningitis may be more frequent in EGFR mutations patient, those who are having a mutation, even T790 mutation, or the uncommon mutation of EGFR in clinical practice. Next slide, please. Next slide, please. So just see, the mets are seen commonly in lung cancer, whether this is adrenal mets, liver mets, contralateral lung mets, bone mets, but the quality of life is totally hampered by the brain mets. So this you can compare by the bar, that if there is a brain mets, the quality of life is totally different in such patient, and worse if there is a brain mets. Next slide, please. So brain mets in EGFR advanced non-small cell lung cancer, what is the role of TKI, especially the first generation, second generation, and third generation? I would like to convey, as Dr. Bharat Dua clearly mentioned about that, third generation TKI crosses the blood-brain barrier and showing response even in brain mets, which is not seen with the first line and second generation TKIs. Next slide, please. So what are already know, we know that brain is the sensory site in majority of cancers. You can see in all solid tumor and even in lung cancer, and protection is by the blood-brain barrier. Up to 40% of the patient with non-small cell lung cancer, EGFR mutation, basically develop the brain mets, as compared to wild type, roughly 20 to 22%. And blood-brain barrier is crossed by the third generation TKI, and that's why there is a role of osimertinib even in brain mets if there is a disease as a leptomeningitis or brain mets, or if patient already received the palliative radiotherapy SBRT, you can immediately switch on third generation TKI in such patient. I would like to discuss the evidence and guidelines in my presentation. Next slide. Next slide, please. So just see the osimertinib differentially penetrate the intact blood-brain barrier in monkey brains in preclinical study, and you can see that this picture is clearly showing the drug in the brain as compared to the other first generation and second generation TKI and other developing drugs. Next slide, please. So osimertinib demonstrate high mouse brain concentration, and I'm showing you the data. If you see osimertinib blood-brain plasma ratio is 3.41% as compared to 0.21%, less than 0.08%, less than 0.36%. This means the third generation TKI crosses the blood-brain barrier, and the graph clearly shows a penetration of this drug despite of blood-brain barrier. Next slide, please. Next slide, please. So osimertinib causes tumor regression in EGFR mutation brain mets in a mouse xenograft model, and this you can see by this picture. And I would like to discuss again how this drug acts even in brains when there is a brain mets. Next slide, please. So osimertinib was homogeneously distributed in all regions of brain in healthy volunteers. Next slide. And again, brain exposure in patient with EGFR mutation, advanced lung cancer patient, You can see the distribution of this drug in brain mets patients, which is showing that this drug crosses the blood-brain barrier and effective even in brain mets patient as compared to first and second generation TKI. Next slide, please. So osimertinib is basically a third generation TKI, bind irreversibly to the EGFR mutation, whether common or uncommon. I'm just saying L858R, exon 19 deletion, even the T790 mutation, which is one of the culprit of majority of time, the resistance, and prolonged progression-free survival, as Dr. Bharat Dua mentioned about in the FLORA trial. And the important thing which I want to convey you, this is the only drug which have shown the overall survival benefit of a TKI even in metastatic disease, even in brain mets. So I would like to say that third generation TKI is very specific for brain mets patient, whether patient received palliative radiotherapy or SBRT or not received. Despite of that, this drug is effective as per the data suggest. Next slide, please. So how does the efficacy of osimertinib compare to first generation TKI in treatment of non-small cell lung cancer? Those who are having a EGFR mutation, 19 deletion, even T790 mutation. Next slide, please. So this is a FLORA trial, which is in length discussed by Dr. Bharat Dua very clearly that there is no comparison. Basically, the first and second generation TKI compared, we extrapolate the data in FLORA trial, but there is a comparison between first generation TKI versus third generation TKI in this trial. And I would like to say metastatic disease seen in 95% of the patient, 35% patient had a visceral mets, and 21% patient had a CNS mets. Next slide, please. Next slide, please. So this FLORA trial clearly shows two important aspects, which Dr. Bharat Dua clearly mentioned, that progression-free survival in FLORA trial is 18.9 as compared to the first generation TKI 10.2. And the progression-free survival and overall survival is very, very important. This is 38.6 versus 31.8 months as per the FLORA trials. Next slide, please. Even you can see the CNS analysis. You can see that with this slide is already shown by Dr. Bharat Dua to you. With non-treated CNS mets, there is a difference. Osimertinib 15.2 versus the first generation TKI 9.6, and without non-treated CNS mets, this is again 19.1 versus 10.9 months with the standard care. And you can see the events are much less with the osimertinib in the tune of 6% as compared to 15% as a progression of disease. Next slide, please. So FLORA trial is one of the basically backbone of third generation TKI, specifically the osimertinib landmark study, and majority of guideline, even the NCCN guideline, even in the lung trials, clearly show that FLORA trial shows overall survival benefit. What about the CNS mets? I'm just highlighting few things to you. Number of patients, 61 in osimertinib arm, 67 in standard care arm. Median CNS progression with survival not reachable with the third generation TKI, while standard first generation TKI 13.9 months, hazard ratio 0.4. CNS overall response rate is 66% as compared to 43% with the first generation TKI. Next slide, please. So intracranially, this slide is again shown by Dr. Bharat Dua to you, and I'm just highlighting that the graph is separated since beginning. This means the third generation TKI play important role even for progression-free survival and overall survival, even in brain mets. This is a full analysis which is showing a graph separated since beginning and widen even at the end. Next slide, please. So FLORA trial clearly shows that CNS progression by a blind independent central review committee occurred in 20% versus the 39% with the first generation TKI, or you can say the standard comparator arm. Next slide, please. So FLORA trial in the FAST, which include patient with and without CNS mets at a trial entry, investigator assessed CNS progression event was observed 6% only in third generation TKI arm versus 16% with the standard first generation TKI arm. Next slide, please. So this graph is clearly showing, and the bars are clearly showing, patient on ositinib, roughly 28% is continuing as compared to 9% with the first generation TKI as an option. Next slide, please. So first generation TKI may delay the need for subsequent therapy, which is 28%, and as compared to 9% with the standard comparative arm. Next slide, please. So some real world evidence of ositinib with CNS PETs. I would like to discuss 3 cases which is published basically regarding the role of ositinib in clinical real world practice. I always believe as a clinician that once we are discussing so many things from trial, I would like to say bench to bedside. As a clinician, I say bench to bedside means what I'm doing in my clinical practice, what are the trial says, what are the clinical cases reported in the journals. I would like to discuss 3 cases with you in 15 minutes duration. Next slide, please. So rapid intracranial response to ositinib without radiotherapy in non-small cell lung cancer patient harboring the EGFR even T790 mutation, which is one of the culprit of most of the time resistance to the TKI. Next slide, please. So first case I would like to discuss. Next slide. So 67-year-old woman. Next slide. So she is a 67-year-old female, underwent right middle lobe resection of the lung because of an early stage of non-small cell lung cancer 9 years ago. Multiple nodules enlarged in both the lungs on CT 7 years ago, which was recognized as a recurrence. Identified the EGFR L858R mutation in exon 21. First generation gefitinib was administered as a first-line chemotherapy for 2 years and a half, 11 months. After third line of cytotoxic drug regime, carboplatin plus pemetrexate, Tegafur, Gemcitabine, Otraciril plus bevacizumab, and docetaxel, erlotinib was administered as a fifth-line chemotherapy, which failed in 3.5 months. After 2 courses of vinorelbine administration as a sixth-line chemotherapy, patient complained of unbearable back pain and spine MRI examination detected multiple thoracolumbar bone mats. Radiotherapy was conducted to control pain and prevent fractures. Bronchoscopy had been conducted as a rebiopsy, detected an additional mutation, T790 mutation, and seventh-line chemotherapy, ositinib 80 mg was administered for the next day from the patient, and PS was 3. Next slide, please. And just see, patient has a brain mets. Pre-treatment, you can see there is a picture which is clearly showing a brain mets. But on day 13, with ositinib, once given to the patient, brain mets picture disappear except one shadow seen in frontal lobe. Even the lung lesions disappear and shrink. Next slide, please. This is a second case which I am again discussing as a real world picture with you. Next slide. Next slide. Next slide. So 76-year-old man. Next slide. So 76-year-old man with 22.5 pack smoking history. Means just see 22.5 packs a year smoking history, underwent right upper lobe resection of the lung because of an early stage of lung cancer 10 years ago. EGFR mutations, exon 19 detected, multiple bone mets as a recurrence emerged 6.5 years ago. And first generation TKI, gefitinib was administered as a first line chemo for 4.5 years. Afatinib was administered for 10 months after sandwich 4 course of carboplatin plus pemetrexate was with bevacizumab, while fourth-line chemotherapy, Tegafur, Gemcitabine, and Otracil was administered, and thoracocentesis was conducted and detected the additional mutation T790 mutation again. I convey you very clearly that T790 mutations are not responding to first and second generation TKI. They are only responding to the osimertinib in clinical practice as well as for the trials results. Osimertinib was administered as a fifth-line chemo or targeted therapy. Next slide, please. In this patient, previous slide, please. Previous slide, please. Previous slide. No. Next slide. Next slide. Next slide. Next slide. Yes. Next slide. Yes. So on day 10 administration of osimertinib, what is the response I would like to discuss with you? And the PS was basically 1. Next slide. You can see there is a pre-treatment shadow. And once patient is on day 10, this cystic lesion was disappear and patient has shown a regression of metastatic disease as well as basically complete remission by the scan. Next slide, please. And even in the X-ray, you can see that pre-treatment and day 14 X-ray shows a decrease of pleural effusion, shrinkage of pulmonary nodules, and on day 31, shrinkage of multiple lung mets, decrease in left-sided pleural effusion. Next slide, please. So this is a third case, a 74-year-old woman with no history of smoking, elevated blood CEA levels. CT scan revealed a 40 millimeter shadow in the upper lobe of the left lung and multiple bilateral small nodule in the entire lung field. Diagnosed clinically T4N1 M1C stage 4B, histopathology adenocarcinoma with EGFR mutations, exon 19 detection seen in the test, in molecular diagnostic test. More than 20 multiple asymptomatic brain mets with a maximum diameter of 12 millimeter was identified in MRI, and osimertinib 80 milligram started as a first-line treatment. Whole brain RT was deferred. Next slide, please. So this is the picture of lung. Means 40 millimeter wide shadows in the upper lobe of the left lung, multiple bilateral small nodule in the entire lung fields. You can see very clearly. Next slide, please. And this is the brain picture. Multiple asymptomatic brain mets lesion, more than 20, with a maximum diameter of 12 millimeter were detected at the first diagnosis. After 5 weeks, the multiple brain mets totally disappear. You can easily compare with above versus below MRI picture, which shows that there is a disappearance of metastatic disease as a complete CNS response was confirmed. Next, please. Next slide, please. So current study clearly shows that intracranial outcome of de novo brain mets treated with osimertinib, third generation TKI, alone in patient with newly diagnosed EGFR mutation patient, whether this is T790 mutation or any uncommon one, responded. Next slide, please. Next slide, please. So this observation clearly shows that retrospective coherent study, patients were selected for an institutional database and they had a EGFR mutation and treated with osimertinib from 2014 to 2022. Received osimertinib alone as a initial therapy after first brain mets diagnosis, had at least one intact brain mets, not previously treated with systemic or local stereotactic, means SBRT versus whole brain RT or surgery, at osimertinib initiations, and had baseline brain MRI, at least one scan, and I would like to discuss that issue with you. Next slide, please. So this is the picture. You can see the baseline MRI. Then 2 months post-ositinib, the lesions disappear, and 34 months post-ositinib, again, there was a complete remission clinically. Initially, there was a regression, and at the 34 months, there was a complete remission seen despite of multiple brain mets. Next slide, please. So observation was there was a 36 patient who had a median interval from brain mets diagnosed to first-line ositinib, initially of 25 days. Total 136 patient previously untreated brain mets were tracked from the baseline. Overall 105 lesions. Previous slide, please. 77.2 had a complete response rate and 31 had a partial response rate for MRI. This reflects a best objective response rate of 100% as per the 3 cases which I have discussed with you, published in the journal. 2-year overall survival was 80%, which was roughly much less. You can say if there is a brain mets, as the data says, roughly 3 to 6 months is a period, but they survive more than 2 years. CNS progression rate at 1 to 3 years post-ositinib were very high. Lesion labels, local failure was estimated to 0.7% and 4.7% and others. Next slide, please. So what are the recent guideline updates suggest? Means we are talking about radiotherapy, but today I'm talking about you can defer the radiotherapy. If patient GC is poor, you can start the 3rd generation TKI, ositinib, as per the real world data and the clinical trials and the case reported in the journals and in the literature. We can start the 3rd generation TKI even in brain mets, and we will get the results in 10 to 1 month period. So you can see even the NCCN guidelines clearly mention about that. Next slide, please. The preferred TKI in present era is ositinib, 3rd generation TKI. If there is a EGFR mutation, whether the common or uncommon, you can start first with ositinib in lung cancer patient, even in a metastatic disease, to get the result. Next slide, please. Thank you very much to listening me patiently. If you have any question, you can ask me. You can ask to any speaker regarding any query in your mind, so we can give a clear picture regarding what we are doing in 2025, what are the guidelines is, and what is going on in future regarding the lung cancer. Thank you very much to listening me patiently. Ashish, if there is no question.
Thank you so much, Dr. Sunil sir, for the exciting academic partner and academic session.
So I personally feel that you please give a vote of thanks to all of the speakers and the delegates, those who listen this scientific program very carefully and learn the subject, the newer concept of lung cancer treatment in today's scientific program.
Thank you so much, sir. Thank you all the faculty and speaker and delegates to join today's session. And thank you, Ashish sir, and thank you, AstraZeneca, for the academic session. Thank you, Sarangni. Thank you, tech support. So can you close the meeting now, sir?
Yes. Good night to all of you, and thank you to all of you.
Thank you,
Okay,
sir.
sir.
Thank
Good
you,
night,
team.
sir.
Okay.
Thank
Thank you.